Sure. I think whenever someone is going to obtain cultures in a patient, they need to ask themselves the question, what am I going to do with the information? And I think we need to distinguish the types of cultures that we're obtaining. I mean, when I ask for cultures, they're usually clinically relevant cultures. I think the patient may have an infection. I want that information to help guide my subsequent antibiotic decision making after I start an empiric regimen. That's very different than surveillance cultures. We don't do a lot of surveillance cultures in the US. There are some parts of the world where they tend to do them just to give clinicians in the hospital a better idea of what the predominant pathogens are within a particular patient. And that way, if that patient were to become infected, you could treat them. That's not something we do in the US because in general, when clinicians in the US get a positive culture, they treat it. And we have to be careful in that regard because we don't want to be treating patients who are simply colonized with bacteria, who are not infected with them. And that's why it becomes important when you're getting your cultures, you have to make a decision in your own mind. Is this patient infected? If they are, what am I going to start them on with an empiric regimen? And then how is that information from the culture going to impact what I do subsequently?